Antihypertensive Pharmacology, Core Concepts for the Exams. This video is new invention of Pharmacy Prep Pharmacast. This include video and also past podcast version combined together, and this video especially focus on the high yield points on antihypertensive pharmacology, which zeroes in on most commonly tested questions in the board exams. Let's start.
Okay, first, the core mechanisms of action, how these drugs actually do what they do, you know, how they lower blood pressure.
Super important. You got to understand the how.
Absolutely. It's not just memorizing names. If you get the mechanism, a lot of the other pieces start to click into place. It provides a framework.
Makes sense. Okay, what's number 2?
High-yield side effects. This is huge for exams.
Oh, yeah. They love testing side effects. And it's critical for, actual practice, too.
Exactly. Knowing the key adverse effects, the ones that differentiate drugs or raise red flags, vital, both for exams and for patient safety down the line.
Couldn't agree more. And the third area?
Clinical uses, connecting the dots. When do you use this drug versus that drug?
The practical application, like specific patient scenarios.
Precisely. Those classic vignettes you see. You know, the patient with hypertension, diabetes, or hypertension and heart failure. What's the go-to agent? That kind of thing.
Got it. So mechanisms, side effects, and clinical use. Those are the big 3.
Yep. We're aiming for a really targeted picture. Not getting lost in every single detail of every single drug.
Right. Avoiding the weeds. Focusing on the key players and the absolute must-know details.
And what's interesting, I think, is how interconnected these 3 are.
How so?
Well, the mechanism often explains why certain side effects happen, right?
Okay, yeah.
And those side effects, in turn, influence the clinical use, who should get the drug, and maybe who shouldn't. It all ties together.
That's a great point. So by focusing on these connections, we're hoping listeners get a deeper understanding, not just rote memorization.
Exactly. That's the goal. So you can actually reason through questions on the exam, not just recall isolated facts. Apply the knowledge.
Which is really the key difference, isn't it, between just passing and actually excelling, being able to apply principles to maybe slightly unfamiliar scenarios?
That's it, that critical thinking piece.
Okay, so for everyone listening, this deep dive is basically designed to be efficient, effective, a way to nail down the critical bits of antihypertensive pharmacology for your boards.
We're giving you the scaffolding, the essential framework to build on.
Perfect. Our goal, just like our sources aimed for, is to make the must-know information clear, memorable, and ultimately help you pass.
Let's do it.
All right, let's dive in then. Starting with those core mechanisms of action. What are the absolute foundational ways these drugs lower blood pressure that we need to grasp?
Okay, but just before we jump right into mechanisms, remember the big picture. We're focusing on high yield to give you that toolkit.
Absolutely. The essential toolkit for tackling those exam questions. Okay, ready now? Let's unpack mechanism number 1.
Sounds good. And maybe just one last thought for later.
Sure.
As you study other topics, think about this approach. Can you identify the core high-yield elements there too?
That's a really useful takeaway. How can you find the must-knows in any subject? That's actually a great question for efficient learning. Food for thought.
Definitely. It's about strategic studying, not just volume.
Okay, now let's hit those mechanisms.
So, let's get started. How does the body keep blood pressure in check normally? Like, what's going on there?
Well, the fundamental equation for blood pressure is blood pressure equals cardiac output multiplied by peripheral vascular resistance.
Okay.
So, cardiac output, what is that? That's the volume of blood pumped by your heart per minute. So think about the heart as a pump. And then peripheral vascular resistance is essentially the resistance to blood flow in your arteries. So, how constricted are those blood vessels? Are they nice and relaxed and open, or are they kind of tight and constricted? So if you think about it, a typical blood pressure, a healthy blood pressure, is around 120 over 80 millimeters of mercury.
Okay. Yeah. So if you're above that,
Yeah.
then there's something going on. You're outside of that normal range.
Yeah.
And that's where these drugs come in, right?
Exactly.
So what are the main things that can go wrong?
Yeah.
Like what are the main sort of physiological imbalances that can lead to high blood pressure? And then we'll talk about how the drugs target those.
Yeah, absolutely. So We can look at, several key players here. One of the big ones is overactivity of the RAS, the renin-angiotensin-aldosterone system.
Right.
Think of RAS as kind of like this hormonal system that, really helps to conserve sodium and water in the body. And it also can constrict blood vessels. So, when that system is overactive, that can definitely contribute to hypertension. Another big one is increased sympathetic nervous system activity. That's your fight or flight response.
Oh, yeah.
That can increase your heart rate, cause vasoconstriction, get you ready to run from a tiger. But if it's chronically elevated, that can definitely contribute to high blood pressure.
Right.
And then, we also have things like, too much sodium and fluid retention, increased stiffness or constriction of the blood vessels themselves. So, that's increased vascular resistance.
Right.
And even issues with the endothelium, which is the inner lining of your blood vessels.
Oh, okay. Wow.
Yeah.
It's pretty complex, huh?
It is. There's a lot of interplay, and it's really fascinating how this RAA system, which you might initially think of as being centered around the kidneys, really has these widespread effects. It affects vascular tone, it affects fluid balance throughout the body, so it highlights how interconnected all of these physiological systems are.
Okay, so we have this sort of landscape of what can go wrong. So let's map the drugs to these targets. So first up, let's talk about ACE inhibitors. Those are the APRIL drugs like lisinopril. How do they work? Where do they fit in?
So ACE inhibitors, as the name suggests, they block the angiotensin converting enzyme, or ACE. ACE is responsible for converting angiotensin acet into angiotensin II. Angiotensin II is a very potent vasoconstrictor, meaning it makes the blood vessels narrower. It also stimulates the release of aldosterone, which causes the kidneys to retain sodium and water, and all of these actions contribute to increasing blood pressure. So by blocking ACE, you decrease the production of angiotensin II and reduce these effects.
Got it. So it's blocking this key enzyme, and then that has this downstream effect of reducing angiotensin II. And what does that reduction in angiotensin II actually do? Like, how does that affect blood pressure through those physiological mechanisms we just discussed?
Right. So when you have less angiotensin II, there's less stimulation of aldosterone release from the adrenal glands. Aldosterone normally tells the kidneys to hold on to sodium and water, so when you reduce aldosterone, you get less sodium and water retention, which means lower blood volume and ultimately lower blood pressure. Angiotensin II also stimulates the release of antidiuretic hormone, ADH, from the pituitary gland, which also promotes water retention, so that's reduced as well. And then, directly, because angiotensin II is a vasoconstrictor, by blocking its formation, you're promoting vasodilation, widening of the blood vessels, which directly lowers peripheral vascular resistance.
Wow. So it's really attacking it on multiple fronts. It's really like a multi-pronged approach there.
Absolutely. It's a very effective way to target this system.
I remember from school the ACE is just in the kidneys, though, right?
That's a really important point, and it's crucial for understanding why ACE inhibitors work so well. You might think that since the RAAS pathway is so closely linked to the kidneys, ACE would only be found there. But actually, it's predominantly found in the endothelial cells lining blood vessels throughout the body. Yeah. So that widespread presence helps explain why these drugs can be effective in lowering blood pressure, even in people who might have normal renin levels. It's not just about what's happening in the kidneys, it's also about what's happening locally in the blood vessels themselves.
Okay. That makes a lot of sense. And there's also that connection with bradykinin, right?
Exactly. Remember how we talked about ACE being the enzyme that converts angiotensin I to angiotensin II? Well, ACE is also the primary enzyme responsible for breaking down bradykinin, which is a very potent vasodilator, meaning it widens blood vessels.
Okay.
So by blocking ACE, you're not only reducing the production of angiotensin II, but you're also preventing the breakdown of bradykinin, which leads to an increase in bradykinin levels and even further vasodilation.
Oh, so it's kind of like a double whammy in a good way.
Exactly. It's
Yeah.
like hitting two birds with one stone. This has been a big deal in practice because that difference in how ACE inhibitors affect bradykinin compared to other drug classes, it has a big effect on how patients tolerate the drug and if they'll keep taking it, Even this small pathway, it turns out, is pretty important for patients. This might also explain why they can lower BP even with normal renin levels, because it might be this bradykinin local tissue ACE activity that's playing a bigger role.
I see. Okay. So that's how they work. But what are the must-know side effects for the board exam?
Well, the most common ones you'll see are hypotension, of course, which is low blood pressure, sometimes a maculopapular rash, And a very characteristic side effect is a persistent dry cough,
Oh, right.
which can be quite bothersome, and it occurs in a significant percentage of patients, maybe as high as 35%.
Okay. Wow.
Yeah, headaches are also relatively common, so, those are the more frequent side effects.
That dry cough, that's kind of like a hallmark of ACE inhibitors.
It's a big giveaway. If you see that in a question stem on the exam, think ACE inhibitors. But then there are the less common but more serious issues.
Right. So what are those?
So angioedema is a rare but potentially life-threatening side effect. It involves swelling of the lips, tongue, throat, and face, which can obstruct breathing.
Oh, wow.
Yeah, it's a big deal. If it happens, you have to stop the drug immediately, and the patient may need emergency treatment. It's also important to note that there have been some reports of cross-reactivity with ARBs, the angiotensin the receptor blockers, in individuals who've had angioedema on an ACE inhibitor. So that's something to keep in mind. Another serious concern, though less acute, is hyperkalemia, high potassium levels in the blood. This is because of the reduced aldosterone activity.
Okay. Makes it, and there's that big contraindication in pregnancy, right?
Absolutely. ACE inhibitors are absolutely contraindicated in pregnancy at all stages.
Mm.
First trimester exposure can cause congenital malformations, particularly of the cardiovascular and central nervous systems. And then in the second and third trimesters, there's a risk of serious neonatal problems, like kidney failure and even death. So this is something that pharmacy professionals really need to counsel patients on.
Okay. Yeah, for sure. All right. So that was a pretty comprehensive look at ACE inhibitors. Let's move on to ARBs now, the angiotensin the receptor blocker. So these are the drugs that end in sartan, like losartan. How do they compare to ACE inhibitors in terms of their physiological impact?
Right. So while ACE inhibitors prevent the formation of angiotensin II, ARBs take a different approach. They directly block the angiotensin II type 1 receptor, the AT1 receptor. So think of the AT1 receptor as like the docking site for angiotensin II. This is where angiotensin II binds to exert its effects. ARBs essentially block that docking site, so angiotensin II can't bind and trigger those downstream actions.
Oh, I see. So they're still essentially counteracting the effects of angiotensin II, just at the receptor level, rather than by preventing its production. Right.
Exactly. By blocking the AT1 receptor, ARBs prevent angiotensin II from doing its thing, which is vasoconstriction, stimulating aldosterone release, activating the sympathetic nervous system, releasing ADH, and constricting the efferent arterioles in the glomerulus, which is a part of the kidney involved in filtration.
Okay, so similar ultimate effects on blood pressure then. But you mentioned earlier that there's a key difference when it comes to bradykinin, right?
Yeah, that's right. Unlike ACE inhibitors, ARBs don't inhibit the breakdown of bradykinin. That's because they don't interact with the ACE enzyme at all. And this is a major reason why ARBs have a much lower incidence of that persistent dry cough that's so common with ACE inhibitors.
Oh, okay. So that makes them a good alternative for patients who can't tolerate that cough. What are the main side effects we need to remember for ARBs for the exam?
Well, the side effects are generally similar to ACE inhibitors, minus that pesky cough. You still have the potential for hypotension, dizziness, hyperkalemia, because you're still affecting the aldosterone pathway. Headaches are also possible. And while it's less common than with ACE inhibitors, angioedema is still a potential, though rare, risk with ARBs. The mechanism here is thought to be through different pathways that affect bradykinin or other inflammatory mediators.
Got it. So similar side effects, just less of the cough. So
Yeah.
AOBs are a good substitute when that ACE inhibitor cough is an issue. Let's switch gears and talk about diuretics now, specifically thiazides, like hydrochlorothiazides. How do they work to lower blood pressure?
Thiazides, drugs like hydrochlorothiazide, clothalidone, indapamide, they're a mainstay in hypertension treatment. They're considered equally effective at lowering blood pressure. They primarily work in the distal convoluted tubule of the kidney.
Okay, and what's their mechanism of action there?
So they work by inhibiting the sodium chloride symporter, the Na+Cl symporter. This transporter is responsible for reabsorbing sodium and chloride ions from the urine back into the blood. So by blocking it, thiazides reduce the reabsorption of these ions.
Okay.
And since water follows sodium, you get less water reabsorption, leading to a decrease in blood volume and ultimately lower blood pressure.
Okay.
Now, what's interesting is that thiazides also increase the reabsorption of calcium in the kidney.
Okay. So That's the diuretic effect and the impact on blood volume. What are the high-yield metabolic and electrolyte side effects that we need to remember for thiazides? I remember there's a good mnemonic for that.
Oh, yeah, there is. A common mnemonic for the metabolic side effects is hyper-GLUC.
Okay.
So hyper stands for, all these increases. It's hyperglycemia, so an increase in blood glucose, hyperlipidemia, increases in cholesterol and triglycerides, hyperuricemia, an increase in uric acid, which can lead to gout, and hypercalcemia, an increase in serum calcium.
Wow. It's a lot of hypers.
Yeah.
So that covers the hyper part. What about the electrolyte imbalances that thiazides can cause?
Right, so thiazides can cause a number of electrolyte imbalances. The main ones to know are hypokalemia, low potassium, hyponatremia, low sodium, hypomagnesemia, low magnesium, and hypochloremia, low chloride. Other possible side effects include acute gout attacks because of the hyperuricemia, metabolic alkalosis, and, some people experience sexual dysfunction.
Right. Wow, that's a lot. And those electrolyte imbalances, especially the hypokalemia and hypomagnesemia, those can have some pretty significant clinical implications, right? Especially in certain patients.
Absolutely. So low potassium and magnesium can cause muscle weakness, fatigue, cramps, and even more serious issues, like an increased risk of cardiac arrhythmias, particularly in patients who are also on digitalis medications, or those with left ventricular hypertrophy, or those with ischemic heart disease. So it's something to really pay attention to. Now, it is worth noting that using lower doses of thiazides is generally associated with a lower risk of causing significant electrolyte disturbances. So that's something to consider.
Okay, that's good to know.
Yeah.
So it's about finding that balance between efficacy and safety.
Yeah.
All right, let's move on to beta blockers now. So this is a class of drugs that has different subtypes that act a bit differently, right?
Yeah, that's right. So beta blockers, they primarily work by blocking the effects of the sympathetic nervous system on the heart. So remember that fight or flight response we talked about earlier? Beta blockers kind of put the brakes on that. We categorize beta blockers based on their selectivity for different beta adrenergic receptors. So we have the cardioselective beta-1 blockers like atenolol, bisoprolol, esmolol, metoprolol, nebivolol. You can remember those with the mnemonic ABEMN.
Okay.
These drugs mainly target beta-1 receptors, which are mostly found in the heart. So blocking those receptors leads to a decrease in heart rate, slows down electrical conduction in the heart, and reduces the force of contraction of the heart muscle.
Okay.
And all of these things help to reduce cardiac output and lower blood pressure.
Got it. So they're more targeted in their action. What about the non-selective beta blockers?
Right, so the non-selective beta blockers, those are drugs like propranolol, pindolol, nadolol, timolol, levobunolol. They block both beta-1 and beta-2 receptors. So while they also reduce heart rate and contractility, like the cardioselective ones, blocking beta-2 receptors can cause some other effects. For instance, beta-2 blockade can decrease the release of renin from the kidneys, which then leads to lower angiotensin and aldosterone levels. However, this can also cause bronchospasm, which is why you generally don't want to use these drugs in patients with asthma or COPD.
Right, makes sense.
Another important thing to remember is that beta blockers can mask the typical signs of hypoglycemia, like tremor and a rapid heartbeat. So that's a big concern for patients with diabetes who are prone to low blood sugar.
Okay, yeah, that's really important to remember. And then, we have the mixed alpha-1 and beta blockers. Where do they fit in?
Yeah, so these are drugs like labetalol and carvedilol, and they have kind of a dual mechanism of action. The beta blockade, both beta-1 and sometimes beta-2, contributes to the reduction in heart rate and contractility, while the alpha-1 blockade causes vasodilation, so you get a decrease in peripheral resistance as well. Labetalol is particularly important because it's used in managing hypertension during pregnancy and in hypertensive emergencies. That's because it can lower blood pressure without significantly reducing blood flow to the placenta.
Right.
Carvedilol has shown to be beneficial in patients with heart failure, likely due to its combined effects and potential antioxidant properties.
Okay, so it's a pretty diverse group of drugs within the beta blocker class.
Yeah.
With different mechanisms. So for the board exams, what are some of the common side effects we need to keep in mind for this whole class?
Right, so common side effects include bradycardia, which means the heart rate is too slow, typically below 40 beats per minute. Then you have Raynaud's phenomenon, which is vasoconstriction in the fingers and toes, usually in response to cold. And then there's the potential for causing or worsening first-degree heart block, which is a delay in electrical conduction in the heart. On an EKG, you'll see a prolonged PR interval.
Okay.
As we mentioned, the non-selective beta blockers can cause bronchospasm in certain people, and they can mask the symptoms of hypoglycemia. And then there are some nervous system side effects, things like fatigue, insomnia, depression, and even vivid dreams or nightmares.
Wow, that's a pretty wide range.
It is. It's important to be aware of all of those.
Okay, so last question about beta blockers. Are there any key pharmacokinetic differences between the different beta blockers that are worth knowing for the exam?
Yes, there are. So, for example, propranolol and metoprolol undergo extensive first-pass metabolism in the liver. That means a lot of the drug is metabolized before it reaches the systemic circulation. Atenolol and natalol have longer half-lives and are eliminated primarily by the kidneys. So, if a patient has kidney problems, their dose may need to be adjusted. And then the degree of lipophilicity, how fat-soluble they are, also varies between the different beta blockers. More lipophilic beta blockers, like propranolol, can cross the blood-brain barrier more easily, so they might cause more central nervous system side effects compared to less lipophilic drugs like atenolol.
Okay. Well, that was really helpful. I think we covered a lot of ground today. It's a really complicated topic, but I think you did a great job of breaking it down and making it more understandable.
Well, thank you. My goal was to really emphasize the importance of understanding the mechanisms of action of these drugs and how they relate to the underlying physiology. It's not enough to just memorize names and side effects.
Right, that's the key
Those are
takeaway.
the key side effects, the things that actually matter for understanding and for those exams.
Okay, let's dive straight in then. Calcium channel blockers, CCBs. What's the basic idea? What are they doing?
Well, fundamentally, they block these voltage-sensitive calcium channels.
Okay.
And that stops or at least reduces calcium getting into heart muscle cells and smooth muscle cells.
Less calcium means
Relaxation.
precisely
Yeah.
relaxation. In the blood vessels, that means they widen. In the heart, it can affect contraction and heart rate, right? Relaxing things, lowering blood pressure. Now, the source material splits them into two main groups, yeah. Dihydropyridines and non-dihydropyridine.
That's a really crucial distinction.
What's the key difference we need to nail down?
Okay, so dihydropyridines, think amlodipine, nifedipine, those kinds of names, they act primarily on the smooth muscle in your blood vessels.
So vessel focus.
Vessel focus. They cause vasodilation. The non-dihydropyridines, that's your diltiazem and verapamil, they have a much bigger effect on the heart's electrical system.
Ah, the nodes, SAV nodes.
Exactly. They slow things down there.
Yeah.
So you're choosing mainly vessel widening or mainly influencing heart rate and conduction. It dictates how you use them.
Got it. Okay, let's zoom in on the dihydropyridines first. Vasodilation, lower resistance. Where are we typically using these?
Main uses are hypertension, so high blood pressure, and angina, that chest pain from lack of blood flow.
Makes sense. What about the flip side, the side effects? I always hear about one specific thing with the legs.
Yes, ankle edema, swelling. Very, very common with these. You also see things like flushing, headache, and interestingly, reflex tachycardia.
Reflex tachycardia. Okay, hold on. If it's lowering blood pressure by widening vessels, why would the heart speed up? That seems counterintuitive.
Yeah, it does, but it's the body fighting back, essentially. You have these sensors, baroreceptors that detect the drop in pressure.
Right.
They signal the sympathetic nervous system, like, hey, pressure's low. And the response is to try and compensate by increasing the heart rate.
Ah, okay, so it's a reflex to the drug's action.
Exactly, a compensatory mechanism.
My document also lists GERD, acid reflux. How does a blood pressure med cause heartburn?
Well, it's that smooth muscle relaxation again. These drugs can relax the lower esophageal sphincter.
The valve at the top of the stomach.
Right. And if that valve gets too relaxed, stomach acid can splash back up into the esophagus, hence GERD symptoms.
Interesting link. Now, the source says most dihydropyridines might slightly weaken heart contraction, a negative inotropic effect. But amlodipine and philodipine are exceptions. Why flag that?
Yeah, that's a good point. A negative inotropic effect might not matter much in a healthy heart.
Okay.
But if someone has, say, borderline heart failure, weakening the pump further isn't ideal.
Right.
So knowing that amlodipine and philodipine don't really do that makes them potentially safer options in those patients.
Good distinction. Okay, switching gears to the non-dihydropyridines. Diltiazem, verapamil, we said they hit the heart's electrical system more. So main uses.
Because they slow down the SA and AV nodes, they're primarily used for arrhythmias, irregular heartbeats, and also angina. They control the heart rate, help regulate rhythm.
And the key side effects to watch for here.
The big ones, definitely for exams, are bradycardia's slow heart rate and constipation. especially with verapamil.
Constipation with verapamil, that one definitely pops up.
It does, yeah. About 7% of patients, the source says.
And there's a contraindication mentioned, a time not to use them.
Absolutely. You avoid them in patients who already have heart block or significant bradycardia.
Because they'd slow things down even more.
Exactly.
Yeah.
Could be dangerous.
Yeah. Okay, crucial point. The document highlights a key exam takeaway for diltiazem and verapamil. What's the essence of that?
The main thing to remember is that both can cause these cardiac conduction issues, bradycardia, AV block. They can even potentially worsen heart failure.
Right.
And again, that specific link between verapamil and constipation is worth remembering.
So unlike the dihydropyridines, which are mainly about the vessels, these guys have a more direct, significant effect on the heart itself. Rate, contraction.
Precisely. And the source notes verapamil generally has a stronger negative inotropic effect than diltiazem.
So potentially more likely to cause issues in someone with a weaker heart?
Potentially, yes. And it slows the heart rate and AV conduction more significantly than diltiazem, though diltiazem does it too, just usually to a lesser extent. That difference can matter clinically.
Okay, clear distinction. Let's shift to alpha blockers now. Before the drugs themselves, what do alpha-1 receptors do in the blood vessels normally?
Okay, so alpha-1 receptors sit on vascular smooth muscle when things like adrenaline bind to them.
Catecholamines.
Right, catecholamines. When they bind, the vessel constricts, tightens up, blood pressure goes up.
So if we block those receptors,
Then the catecholamines can't bind as effectively. The vessels relax, they dilate.
vasodilation again?
Yep, leading to lower blood pressure.
The source divides these into non-selective and alpha-1A selective. Why the split?
Good question. The non-selective ones, prazosin, terazosin, doxazosin, they block, well, pretty much all alpha-1 receptor subtypes, used mainly for blood pressure.
Okay.
The alpha-1A selective ones, tamsulosin, alfuzosin, silodosin, they preferentially target the alpha-1A subtype, which is found a lot in the prostate and bladder neck.
So that's why they're used for BPH, benign prostatic hyperplasia.
Exactly. They're functionally uroselective. Helps relax things there to improve urine flow, often with maybe fewer blood pressure side effects than the non-selective ones.
Makes sense. What about general side effects across the board for alpha blockers?
The document mentions cardiovascular and ophthalmologic side effects as occurring in at least 1% of people.
Eye side effects. That's unexpected for a BP med. What's the specific issue there?
Yeah, there's a really critical one, especially linked to tamsulosin. It's called intraoperative floppy iris syndrome, or IFI.
Floppy iris syndrome.
It can seriously complicate cataract surgery. It's vital to know if a patient is on or has taken tamsulosin before they have that surgery. Definitely high yield.
Wow. Okay. Need to scream for that. The document also touches on sexual function.
Yes, ejaculation disorder can happen. It's noted as being particularly common with silodosin, potentially quite a high percentage, actually.
Something important to discuss with patients. Now, the classic high-yield side effect. The first dose phenomenon. What is that?
Ah, yes, first dose phenomenon. It's basically orthostatic hypotension blood pressure dropping suddenly when you stand up.
Leading to dizziness, fainting.
Exactly. Dizziness, feeling faint, palpitations, sometimes even actually fainting. Syncope usually happens within like 1 to 3 hours of the very first dose or after you increase the dose.
With all of them?
It's more commonly associated with the non-selective ones like prazosin. The source says it's less frequent with the alpha-1A selective agents like tamsulosin. Still possible, but less common.
So that first dose needs caution. Maybe take it at bedtime.
Exactly. That's the standard advice. Start low, take it at night, be careful getting up. Especially important for older folks.
Good practical tip. Okay, moving centrally now. Central acting alpha-2 agonists. These work in the brain, right? How?
Yeah, these are drugs like clonidine, mesyldopa. They stimulate alpha-2 receptors in the brain.
Okay, and stimulating those does what?
It basically tells the brain to dial down the sympathetic nervous system outflow. Less fight or flight signals going out.
And increases vagal tone. More rest and digest.
Sort of, yeah. Increases vagal influence. The net result is reduced sympathetic activity.
So what does that translate to physically?
You get decreases in heart rate, how much blood the heart pumps out, cardiac output, the resistance in the vessels, peripheral resistance, even renin activity goes down. It also dampens those baroreceptor reflexes we talked about earlier.
So a pretty widespread calming effect on the cardiovascular system, initiated from the brain. What about side effects with long-term use?
Well, they can cause sodium and fluid retention over time, which can actually blunt the BP lowering effect sometimes. Other things include potential for depression, that orthostatic hypotension again. dizziness, and anticholinergic effects, dry mouth, constipation, that sort of thing.
And the document flags a major issue if you stop them suddenly. Rebound hypertension.
Yes, this is critical. Abruptly stopping these drugs can cause a dangerous, rapid surge in blood pressure.
Why does that happen?
The thinking is the drug has been suppressing norepinephrine release. You suddenly remove that brake and you get this compensatory overshoot, a big release of norepinephrine.
So never stop them cold turkey.
Absolutely not. They must be tapered off slowly under supervision. Really important point.
Definitely. Okay, last group for today. Direct arterial vasodilators. Hydralazine and minoxidil. How do they work?
These act directly on the smooth muscle in the arterioles, the smaller arteries.
Just relax them directly.
Yep.
Direct relaxation, widening the vessels, reducing resistance, lowering BP. Pretty straightforward mechanism.
But the body doesn't just sit back and accept that, does it?
No. The body rarely does. That rapid vasodilation triggers those baroreceptors again. Big time.
So compensation kicks in?
Oh, yeah. Increased sympathetic drive, heart rate goes up, cardiac output goes up, renin gets released. The body tries hard to counteract the drop in pressure.
Which is probably why they're often used with other drugs, like beta blockers, maybe.
Exactly. You often need something else to manage that reflex sympathetic activation.
Now, hydralazine specifically, there's a unique side effect mentioned, lupus-like syndrome.
Yes, that's a well-known one for hydralazine. It's dose-related and usually reversible if you stop the drug.
More common in certain people?
It's more common in slow accelerators, people whose bodies metabolize the drug more slowly, so levels build up.
Okay.
But the source notes, it's usually avoidable if you keep the daily dose below 200 milligrams. Dosage management is key there.
Got it. Careful dosing minimizes that risk.
Precise. Well, this has been really helpful. We've covered a lot of ground on these